My name is Labaki. I am an oncology research fellow at Dana-Farber Cancer Institute, and I will be talking about our work recently published in Immuno-Oncology about the interplay of immunotherapy and immunosuppression among patients with cancer and COVID-19 as part of the COVID-19 and Cancer Consortium. Starting by general background, patients with cancer present a high rate of severe outcomes during COVID-19 infection and have been previously characterized as a very vulnerable population. Additionally, patients with cancer receive or are administered systemic anti-neoplastic therapies. There are various forms of systemic therapies, including cytotoxic chemotherapy, targeted therapies, and other cellular therapies also. One specific type of therapy that works by acting on the immune system is the family of immunotherapies. This class of drugs work by acting on the immune system to activate it and eventually lead to cancer cell killing. From a biological perspective, SARS-CoV-2, the virus responsible for COVID-19, has been characterized by the fact that it induces immunosuppression. So it upregulates immune exhaustion markers, and that also translation studies have shown that patients with COVID-19 present also some sort of depletion of CD8 positive T cells. And this is why today many clinical trials are trying to evaluate immune checkpoint inhibitors as a potential therapy for patients with COVID-19. And these trials are registered as part of clinicaltrials.gov. Additionally, there are some concerns in the medical field, and more specifically in the oncological medical community, about the potential impact of immune checkpoint inhibitors in regard to the outcomes of patients with cancer and COVID-19. Because COVID-19 has been characterized by a specific setting, which is a cytokine storm, and corresponds to a combination of biological and clinical inflammation. And so patients with COVID-19 could present with inflammatory complications. These could be in relation to the cytokine storm, or also a multi-inflammatory syndrome. And so the fact that immune checkpoint inhibitors activate the immune system, there was also a worry about a potential exacerbation of inflammatory outcomes among patients with cancer and COVID-19 who are receiving immune checkpoint inhibitors. So previous studies that aim to evaluate immune checkpoint inhibitors in regard to their impact of the outcomes of patients with cancer and COVID-19 did not have any unique conclusion. So some studies did not show any association between immune checkpoint inhibitors and COVID-19 outcomes among patients with cancer, while some studies showed worse outcomes in patients with cancer treated with immunotherapy and during COVID-19 infection. However, there are two limitations of these studies so far. One, a limited sample size, and two, the fact that some of these studies did not correct for important and relevant confounding factors that could be influencing some of the results obtained. So as part of the COVID-19 and Cancer Consortium, we decided to evaluate as thoroughly as possible the interplay between immunotherapy and the outcomes of patients with cancer during COVID-19 infection. Additionally, we looked also at the other spectrum. So immunotherapy represents a state of activation of the immune system. So we thought to look also at the other end of the spectrum, which is the impact of immunosuppression, especially considering that many patients with cancer have baseline immunosuppression due to multiple drugs that could be administered initially to these patients, and not in relation to COVID-19 infection, but rather in relation to their malignancy or other comorbidities. So we looked at baseline immunosuppression as defined before COVID-19 infection. As part of the CCC19 consortium, we evaluated more than 12,000 patients with cancer and COVID-19. We stratified these patients into 3 groups. An immunotherapy group, a group of patients that did not receive any systemic therapy, and a third group of patients that did receive antineoplastic systemic therapies that were not immunotherapy. The definition of the receipt of any systemic antineoplastic therapy, whether it is immunotherapy or other types of therapy, so the immunotherapy group or non-immunotherapy group, was based on a recent administration of systemic therapy, meaning during the past 3 months before COVID-19 diagnosis, for a simple reason, which is we believe that the impact of systemic therapies is better evaluated when looking specifically at patients who received recently these therapies in relation to their outcomes with COVID-19. And we conducted a comprehensive analysis which incorporated many confounding factors. The primary outcome was COVID-19 severity, and this is a clinical outcome, a pure clinical outcome. The secondary outcome, or the secondary endpoint, was the incidence of cytokine storm. As previously mentioned, cytokine storm is based on clinical and biological criteria in order really to fulfill the definition of a cytokine storm, which corresponds to a state of systemic inflammation with end organ damage. So we based our definition on previous studies detailing the biological and clinical characteristics of cytokine storm. And as previously mentioned, we included a very comprehensive set of parameters as potential confounding factors in our analysis, meaning vaccination status, meaning time of diagnosis with COVID-19, meaning cancer stage, the progressive state of cancer, so whether it is active and progressing, or whether it is in remission, and age, and many other clinical and demographic parameters. And we, in relation to the potential interplay in terms of moderating factors between immunosuppression or baseline immunosuppression and immunotherapy, we looked also at the interaction term between these 2 variables as part of the multivariate analysis that we conducted. In summary, what we found was that in patients with cancer and COVID-19 who had baseline immunosuppression, the recent administration of immunotherapy led to a high rate of worse outcomes as compared to a similar population, so patients with cancer and COVID-19 who did not have immunosuppression. So immunotherapy was associated with worse outcomes, specifically in the immunosuppressed patients with cancer and COVID-19, as opposed to the non-immunosuppressed population, and with a much higher rate of severe outcomes, talking 3 to 4 times more severe outcomes. In regard to the secondary endpoint of cytokine storm, we also saw very similar results. So immunotherapy was associated with worse outcomes, specifically in the subgroup of patients with immunosuppression. And so we identified here an interplay between immunotherapy and immunosuppression in relation to both the primary and secondary outcomes, and that the administration of immunotherapy as compared to no recent systemic therapy was associated with worse outcomes, specifically in patients with immunosuppression, and we did not see this association in patients who did not have any baseline immunosuppression. So looking at the stratified analysis by immunosuppression status, in the non-immunosuppressed group, or the patients that did not have any baseline immunosuppression, there was no association between immunotherapy and the primary or the secondary outcomes in relation to a high rate of severe COVID-19 or a high rate of cytokine storm. However, when looking in the immunosuppressed population, as compared to patients who did not receive any recent systemic antineoplastic regimen. Patients who received immunotherapy presented with a high rate of worse outcomes and a high rate of cytokine storm. We also saw these findings in the non-immunotherapy group, meaning that patients who did receive recently, as in relation to COVID-19 diagnosis, non-immunotherapy systemic antineoplastic regimen presented with a high rate of worse outcomes and a high rate of cytokine storms as compared to patients who did not receive any recent systemic therapy. And we did not see this association in the non-immunosuppressed population. So when doing a stratified analysis, the association with worse outcomes in relation to non-immunotherapy regimens was seen only in the subgroup of patients with baseline immunosuppression. However, this association, the association with worse outcomes and the association with a high rate of cytokine storm, was more significant in patients who received immunotherapy. And so, in general, as a general conclusion, there is an association of immunotherapy with worse outcomes, specifically in patients who present a state of baseline immunosuppression after confounding for all clinical and demographic parameters that are relevant to this analysis. And this is seen to a lesser extent with non-immunotherapy regimens. So the main conclusion of this study is that there is an interplay between immunotherapy and immunosuppression in relation to COVID-19 outcomes based on the two endpoints, so COVID-19 severity and cytokine storm. There is also a need to stress on the importance not to stop systemic therapies. So it is important to keep in mind that immunotherapy can be life-saving for patients with cancer. Also, non-immunotherapy regimens can also be life-saving for patients with cancer. And so there is a need not to stop these therapies. And the association with worse outcomes does not mean at all that we should stop these therapies. However, patients with cancer who present with baseline immunosuppression are recommended to follow very strict preventive measures in relation to the pandemic. And we are currently at a stage after more than 2 years of a pandemic that we tend, I'm not talking about specific persons, but rather the general population, to not follow very strictly the preventive measures. It is important to keep in mind that specific subgroup of patients who are highly vulnerable to worse outcomes in relation to COVID-19, such as patients with baseline immunosuppression who are to be administered immunotherapy regimens, should follow very strict preventive measures, both at home, in public settings, also when receiving therapy, and that all the persons that interact with them should try also to protect them as much as possible by following these measures, because in this case, they will prevent the specific population to contract COVID-19. And in this case, they would prevent a high rate of worse outcomes in this subgroup of patients. The main message of this study is that the fact that we identified an association with worse outcomes in patients treated with immunotherapy and who have baseline immunosuppression really highlights this population as being highly vulnerable. And so there is a need to follow very strict preventive measures by these patients, their families, and their caregivers, in order to make sure that they do not contract COVID-19, especially at a time where preventive measures are not being strictly adopted in the public setting. And so, more importantly, we should never discontinue life-saving therapies for patients with cancer, especially as this could be really something that will help them cure from their disease, or at least will help improve their outcomes.